Welcome back to this next video in which we are discussing cardiac arrhythmias. Okay, so in this next video what we're going to talk about is atrioventricular re-entrant tachycardia. So we've just talked about atrioventricular nodal re-entrant tachycardia, AVNRT. Now what we're going to talk about is atrioventricular re-entrant tachycardia. And as I say, this one is going to involve both the atria and the ventricles, so it's difficult to categorize this one into whether it is supraventricular or ventricular. You can't really, it involves both of them. Okay, so do not confuse AVRT with AVNRT. The mechanism is quite different here. Okay, it's going to be a re-entrant loop again, but it's not going to be a re-entrant loop that's just localized to the atrioventricular node. It's going to be a rather more dramatic re-entrant loop. Okay, so this is atrioventricular, and then it's re-entrant tachycardia. So it is going to result again in far too high rates of electrical activity generation. So a tachycardia. Okay, right, so what then is going to happen in atrioventricular re-entrant tachycardia? Well, again, just like atrioventricular nodal re-entrant tachycardia, atrioventricular re-entrant tachycardia is an episodic tachycardia. Okay, so normally people who are going to suffer from atrioventricular re-entrant tachycardia, normally their heart rhythms are perfectly fine, they're normally in normal sinus rhythm, but then they can go into an episode of atrioventricular re-entrant tachycardia. Now, in order to actually suffer from this, you need to have a accessory pathway. Okay, let me explain what is meant by this by drawing a picture. Okay, so we will have another picture of the heart. Here our normal cross section. So here is the left atrium here. Here is the right atrium here. Here is the right ventricle here, and the left ventricle here. Okay, right, so remember, in a normal healthy heart, the only window through the atrioventricular septum, this insulation between the atria and the ventricles, is the atrioventricular node. Okay, so here is the atrioventricular node shown in red here. And that's the only way the electrical signal from the atria can actually propagate down to the ventricles. However, in people who are going to suffer from atrioventricular re-entrant tachycardia, there is an additional window. So let me draw this on now. There's an additional route, an additional pathway through the atrioventricular septum. So I've drawn it here in blue. That's probably not a particularly sensible position to have drawn it, because that's reasonably where the tricuspid valve is, but maybe a better place to have it would have been here. Okay, so I'll move it there. So we've got an electrical connection, a bunch of cardiomyocytes that run through the atrioventricular septum, a window from the atria to the ventricles, so an electrical signal could propagate through here. Okay, now if you have one of these structural abnormalities where you do indeed have a pathway, a conductive pathway through the atrioventricular septum that is separate from the atrioventricular node, then this is called an accessory pathway. Okay, so this is what's known as an accessory pathway, and a syndrome where an accessory pathway actually occurs is what's known as Wolff-Parkinson-White Syndrome. So Wolff-Parkinson-White Syndrome is the name for the syndrome that occurs when you have such an accessory pathway. Wolff-Parkinson-White Syndrome. And in the case of Wolff-Parkinson-White Syndrome, the accessory pathway is also known as the bundle of Kent. Okay, so you can call this accessory pathway either an accessory pathway, or you can call it the bundle of Kent. So, if you have an accessory pathway or a bundle of Kent, then you will suffer from a syndrome known as Wolff-Parkinson-White Syndrome, where normally your heart rhythms are perfectly normal, you're in normal sinus rhythm, but you are at risk of having episodes of atrioventricular re-entrant tachycardia, AVRT. Okay, so why then is this potentially extremely arrhythmic, or arrhythmogenic is probably the better word, capable of generating an arrhythmia? Well, look, there is a potential to have a re-entrant loop going around here. Okay, you could have the electrical signal going through the AV node, through the ventricles, then back up our accessory pathway here, back round, and generating a circus rhythm. That is why there is a problem here. However, usually that doesn't occur. As I say, this is a episodic tachycardia. So usually what happens is the sinoatrial node is dominating. So we'll have the sinoatrial node up here, and as usual it will generate electrical signals every 0.8 seconds. What will happen is those electrical signals will propagate down the atria to the AV node and to our accessory pathway down here. Now, the accessory pathway, this is made up of cardiomyocytes that resemble cardiomyocytes in the His-Purkinje system, so specialized conduction cardiomyocytes, okay, and they are capable of conducting action potentials far faster than the atrioventricular node cardiomyocytes are capable of conducting action potentials. So what will happen is the electrical signal will usually end up propagating through the accessory pathway far faster than it will get through the atrioventricular node. So generally, the electrical signal is now unleashed on the ventricles by the accessory pathway, not by the AV node, and therefore instead the electrical signal spreads through the ventricles from here downwards like so. Okay, so this leads to an abnormal ECG, but it isn't too bad. Okay, usually, even though this is happening, the heart functions all right. You do get normal cardiac output reasonably, you get a normal heart rate. So the fact that, yes, the electrical signal isn't going through the normal ventricular conduction system and it isn't being released in the normal way from the bottom upwards, doesn't have too bad an effect. So normally, when you're not in an episode of atrioventricular re-entrant tachycardia, yes, your ECG will look abnormal, but it doesn't make you too unhealthy. So let's draw out what your ECG might look like then when you're in normal sinus rhythm with one of these accessory pathways here. Okay, so the electrical signal will be started off from the sinoatrial node here. It'll propagate down the atria, and of course it will be propagating in the normal fashion, in the anterograde fashion, so you'll get an upward deflection from the isoelectric line for your P wave here. Okay, then it'll arrive at the bundle of Kent here, so you'll get a little bit of time where it's propagating through the bundle of Kent, but of course this will be much shorter than it would be for the atrioventricular node and the ventricular conduction system, because that takes much longer to, well, it takes much longer to go through the AV node. So usually in the ECG you'd have a much longer interval here between the P wave and the QRS complex. So the PR interval, the interval from the start of the P wave to the start of the QRS complex, would be longer in someone without Wolff-Parkinson-White syndrome. Then what you usually see is then a QRS complex that looks like this. Okay, you get a gradual deflection upwards as the electrical signal spreads downwards, and then as it spreads along the entire ventricles you get a large deflection up like this. But because there isn't that normal pattern of the electrical signal gets unleashed firstly on the interventricular septum, so it propagates up this way, then it gets released on the major myocardium, and then on the posterior bits, the QRS complex actually ends up looking much simpler. It's just one great big upward deflection because everything really is always just down now. Okay, whereas with the normal complicated ventricular conduction system, you get the electrical signal released in that complicated way, which gives rise to the normal complicated QRS complex. Here you end up with this much simpler QRS complex like so. Now, this characteristic upward slope here before the major portion here, this has a name. It's known as the delta wave, and it's one of the characteristic things that you would see on an ECG of someone suffering from Wolff-Parkinson-White syndrome. Okay, right, and then of course finally what will happen is you will get a normal T wave because ventricular repolarization will still start at the subepicardial myocardium and work into the subendocardial myocardium. So you'll get a upward deflection as your T wave like so. So that's what the ECG of someone suffering from Wolff-Parkinson-White syndrome would look like when they're not in an episode of the atrioventricular re-entrant tachycardia. So that's when they're in normal sinus rhythm. And as I say, although the ventricular conduction of the electrical signal is abnormal, it doesn't usually actually cause any problems. The other thing to say is that the reason you don't usually get the circus rhythm established is because the electrical signal will be propagating through both the accessory pathway and the AV node. The accessory pathway will conduct the electrical signal faster, so it will release it on the ventricles, and then the electrical signal will make its way up to where the AV node is, and of course will cancel out there. So the electrical signals will end up cancelling out basically, so you don't usually end up with a circus rhythm being established, because the electrical signals coming from both of these end up cancelling each other out. Okay, right. However, there is of course the risk that something goes wrong and then the electrical signals don't end up cancelling each other out, and then you can end up with circus rhythms establishing. Okay, now, there are two possibilities here. Either the electrical signal can go round in the direction where it goes through the AV node, goes through the ventricular conduction system, and then goes back up the accessory pathway, so like so. So it'll go, in fact I'll just draw the ventricular conduction system on. So here is the bundle of His, here is the right bundle branch, here is the left bundle branch. Okay, so either the electrical signal can go down the ventricular conduction system like so, and then it can go up the bundle of Kent here, and then back round like so, and that's known as an orthodromic re-entrant loop. So this is the wait, how am I doing this? No, this has gone wrong. Orthodromic. Okay, so if it goes round in that way, it's known as an orthodromic circus rhythm, or an orthodromic re-entrant loop. Whereas if it goes round the other way, where it goes down the bundle of Kent here, and then stimulates the ventricular conduction system, and then that goes back up to the AV node, and then it goes round the other way, that's known as an antidromic circus rhythm. Okay, so either of these two circus rhythms can be set up if there is some problem potentially with one of these pathways during a normal sinus beat. So if one of them fails to actually conduct the electrical signal just once when we're in normal sinus rhythm, then you have the possibility to set up one of these re-entrant loops. Okay, and it can either get set up orthodromically or antidromically, depending on whether it's the bundle of Kent or the AV node that failed to conduct on that arrhythmogenic beat. Okay, right, so of course this is then going to become the major driver of the electrical signals within the heart. You're going to get a circus rhythm going round and round and round, and depending on which way it's going round, the ECG will look different. So if it's going round orthodromically, i.e. it's going round the AV node through the ventricular conduction system, and it's being released onto the ventricles in the normal way, then you will end up with a normal QRS complex. Okay, then it will go up the accessory pathway here, the bundle of Kent, and then it will be released on the ventricles in a retrograde fashion. So what you'd expect to see is something along the lines of this. So you'd have your QRS complex looking perfectly normal in an orthodromic circus rhythm here. Then what you get is an inverted P wave like so. And then of course it will come back to the AV node, and you then get another QRS complex that would look like so, and it will go on like that. So you'd have QRS complex is normal and an inverted P wave here. Okay, and of course the sinoatrial node would still be trying to generate electrical signals, but it's too slow compared to the circus rhythms. So every time it does generate an electrical signal, it will just meet an electrical signal coming from this circus rhythm here, which will then annihilate it. So you'll get the electrical signal coming up here from the accessory pathway, meeting the electrical signal coming from the sinoatrial node, and they'll just annihilate each other there, and the electrical signal from the accessory pathway will end up going back round the AV node, which is why the sinoatrial node is failing to actually destroy this circus rhythm, because it's just too fast for it. And you might be able to guess then how we can end one of these episodes of atrioventricular re-entrant tachycardia just with the same interventions that we had previously. Okay, so that's what it would look like if it was going around in an orthodromic direction. Let's now talk about what it would look like if we were going around in an antidromic direction. Well, here the QRS complex wouldn't look normal. It would look more like this, because you get the electrical signal coming down the bundle of Kent, okay, propagating all through the ventricles in this way, so you get a QRS complex looking like this. Then it will go up the ventricular conduction system, up the AV node, and then it will be released onto the atria. So you then get, again, an inverted P wave because of the retrograde conduction of the electrical signal up the atria. And again, that retrograde signal would meet the anterograde signal coming from the sinoatrial node, and they continuously be annihilating each other, okay, which is why the sinoatrial node isn't annihilating the circus rhythm, because it's being annihilated itself. The electrical signals from the sinoatrial node are being annihilated too high up, basically. To annihilate the to actually annihilate the circus rhythm, we need the sinoatrial node signal to get down far enough so that the annihilation is actually occurring in the path for the circus rhythm, to actually block it going round and round and round. If it's occurring up here, then it's no use, because the circus rhythm can still go down here. We need the sinoatrial node rhythm to electrical signal to get right down here so that it can actually block the circus rhythm in its path. Okay, right, so that's what it will look like in an antidromic case. So I'll draw a little picture for the antidromic case. You'll get your QRS complex looking like this, then an inverted P wave, then another one of those QRS complexes like so. Okay, so the ECG will look something along the lines of that if we're going round in the antidromic case. So that's the antidromic case, this is the orthodromic case. Okay, right, so now let's talk about the actual treatment for this. So again, to end an episode of this, the treatment is exactly the same as we've talked about for atrioventricular nodal re-entrant tachycardia. What we are going to aim to do is slow conduction down in the AV node, because of course the re-entrant loop involves the AV node. We can slow conduction very well in the atrioventricular node, and if we do that, then this circus rhythm is going to be slowed down, and then we have the hope that the sinoatrial node signal might just make it down all the way down to the atrioventricular node, will meet the electrical signal coming from the atrioventricular node and annihilate it. Okay, now of course I'm talking here about an antidromic one, but the principle is the same for the orthodromic one. So whichever way round the circus rhythm's going, it's going to have to be coming up to the atria somewhere. So if it's going round in an orthodromic way, then the electrical signal will be coming back up to the atria from the bundle of Kent. If it's going round in an antidromic way, the electrical signal will be coming back up to the atria from the AV node. But the point is, somewhere it has to be coming back up to the atria. If we can slow the rate at which it's conducting down there by slowing the rate at which it's going through the AV node, then we have the hope that the sinoatrial node electrical signal will propagate it right the way down here, and then the cells at these boundaries with the accessory pathway and with the AV node here will be refractory when the electrical signal actually arrives from the circus rhythm up here, either up here or up here, depending on whether it's orthodromic or antidromic. And then, of course, bang, it's gone. Okay, it's killed, and then the circuit rhythm's gone, and then the sinoatrial node can take back over, and you'll get normal sinus rhythm returned. So that is how we can end an episode. So how can we do this again? All the interventions that we've just talked about. So the vagal manoeuvre or the Valsalva manoeuvre to increase parasympathetic stimulation to the AV node, and the acetylcholine then will cause a reduction in the rate at which action potentials are conducted along the AV nodal cardiomyocyte cell membranes. Okay, if those manoeuvres are not good enough, and we would ideally like it that they are good enough, because it's always better just to do one of those manoeuvres than have to inject yourself with some drug. But if they aren't working, then we can give drugs. So beta blockers can be used. Again, we know how they work. They will block the beta-1 receptors, block sympathetic tone, which will then lead to a reduction in the rate at which action potentials are conducted along the AV node cells. We can use calcium channel blockers. We again know that those block L-type voltage-gated calcium channels and reduce the rate at which saltatory conduction will propagate along the atrioventricular nodal cardiomyocytes. Or we know that we can now use this adenosine drug, intravenous adenosine, which will activate A1 receptors on the surface of the AV nodal cardiomyocytes, and again will slow the conduction of the action potential along their cell membranes. So that's how you can end an episode of atrioventricular re-entrant tachycardia. Finally, there is actually a way to cure this, of course, which is to destroy this accessory pathway. So the curative treatment here is to actually do catheter ablation of the accessory pathway. So I'll just add that on. To cure this, we can do catheter ablation. So all of those other interventions are just to try and end an episode of atrioventricular re-entrant tachycardia when it occurs. If you want to actually stop it ever from occurring, then just do catheter ablation of this accessory pathway, and then you'll end the syndrome. So that's how you can cure it. Okay, so we will have a break here, and in the next video we're actually going to now move on to ventricular tachycardias, and we'll begin by talking about ventricular ectopic beats and the mechanism by which lidocaine can be used to prevent ventricular ectopic beats, which is a complicated mechanism but which is very satisfying once you understand it.